as best as I can. um, so, all right. So let's jump into it. So hypertension. Most of you guys know about hypertension. It's also known as high blood pressure in Jamaican society, or some people just call it pressure. So any one of those things are synonymous in today's world, and it's an important health problem because it's so common. All right, and unfortunately, or fortunately, depending on how you look at it, it's asymptomatic. So if you know how people work, they don't really believe in something unless they can see it or feel it or hear it. So when you have a disease that is asymptomatic, that can become a problem. However, the good thing is that it's readily detectable. It's easy to do a blood pressure monitor. We use something called a sphygmomanometer, which you guys should be familiar with and maybe know how to use. I'm not sure if you know it at this stage. I'm hoping to use the manual. But most places have automated machines that can do this for you. And depending on the machine, if it's properly validated, gives a pretty accurate reading. So most of the time when you're finished, you won't actually have to do one. But you still have to be aware of how to do one if the need arises, because you don't know where life will take you. And the other good thing about hypertension is that it's easily treatable in the vast majority of people. However, most people will require more than one medication. Only about a third of the hypertensive population will require one medication. Most people require two or more. And it's important because not is it just a number that we're talking about, but there are complications that are associated with it. Because if you have high blood pressure for a prolonged period of time, it causes organs to malfunction. It causes damage to almost every organ in your body because it damages the blood vessels. All right, so that's the essence of it. So if you're damaging the blood vessels and all organs require a blood supply, then theoretically you can end up with organ damage in many different places, and that's a part of what we'll be focusing on today. However, more than 30% of patients who are hypertensive are undiagnosed, so there's even an opportunity to treat these guys or girls up front. So that can be a problem, and the only time you find them out is when they start having complications of their hypertension or end organ damage. The organs that are associated with end organ damage are mainly your heart, your brain, your kidneys, as well as most vessels. So you can have vascular problems being peripheral arterial disease and things such as aneurysms. So, as I mentioned earlier, hypertension is a risk factor for atherosclerosis, and atherosclerosis essentially is a buildup of plaque in the blood vessels. And almost everybody has some degree of atherosclerosis once reach an adult, and studies have shown that have found evidence of early atherosclerosis in people as early as 10 years of age. And it's getting worse as time goes on, a lot of it due to diet and lifestyle changes. Because as compared to, say, 200 years ago, our activity is now much less. People are not walking as far, and people are eating a lot of processed food, which accelerate this process. Also with hypertension, it leads to, on top of atherosclerosis, it actually causes damage to the actual cells, the endothelium, or the lining of the blood vessels, and results in remodeling of the vessel wall. And with increased mass of the vessel media due to proliferation of smooth muscle cells. So it's not, atherosclerosis is not just a simple process of cholesterol or just sticking to the side of the wall, but it's actually infiltrating the layers underneath the endothelium, affecting the endothelium itself and causing other changes in the actual structure with proliferation of smooth muscles as well as fibrous cells. There are different stages of hypertension. Normal is defined as being less than 120/80. And over the years, the actual definition of hypertension has changed. In fact, this definition that I have up on the slide would now be considered old. Okay, in 2017, they revised the guidelines. So according to these older guidelines, so this is based on GNC 7, and there are a number of different societies that have their own definitions. As you go on, you will realize that everybody has an opinion and everybody has a society. But as a general rule, the numbers 140/90 is a good marker to have. And anybody definitely who is 140/90 or above would be considered hypertension. In previous years, pre-hypertension was called 120 to 130, and a diastolic of 80 to 89, and stage 1 being as you see there, and stage 2 also as you see there, systolic of greater than 160, or diastolic of 100 or greater. So that should be equal to or greater than, not for the last line. But in 2017, the American Heart Association had their own reclassification of hypertension, and they're now calling stage 1 hypertension 130 over 80 or above, and stage 2 hypertension 140 over 90 or above. Okay, so those are the changes. Because we have to recognize that a lot of the damage that's done, it's almost like a continuum. So there's almost no hard level that you say, okay, well, fine, you're gonna increase your risk by so much. But it's as your blood pressure gets higher, it's noted that your risk will increase. We spoke about this before. The main organs that we're worried about are your heart, your brain, your eyes, your kidneys, as well as the peripheral vessels. We'll start off with the heart complications. The main ones are heart failure, because if you have chronic overload of your heart, it starts to cause changes in the actual heart muscle. Initially it makes it very stiff, but then over time, your heart actually becomes very weak and dysfunctional as a result of that, leading to a condition called heart failure, which is a clinical syndrome where essentially your heart is unable to meet up with the demands of your body. Coronary artery disease, so the coronaries are the blood vessels that supply your myocardium, or the heart muscle cells, and the coronaries are located on the outside of the heart, or on the epicardium. And because hypertension increases atherosclerosis, this is a reflection of that. Left ventricular hypertrophy is something that we also see, again, as a result of chronic pressure overload. The muscle itself starts to adapt, but actually in a very abnormal way, to cause thickening. So the same thing like when a bodybuilder lifts a lot of weights, so it's against resistance. When your heart has to pump against resistance, it gets thicker. Unfortunately, the heart is already functioning pretty efficiently, and getting thicker doesn't really help the pumping of your heart, and all it does is make it stiffer. Because if you can imagine, when a wall is thicker, it's much thicker and less compliant. And that also becomes a problem, because your heart is required to do two things. It needs to contract, but it also needs to relax. If your heart is getting thicker, as in left ventricular hypertrophy, it doesn't relax very well, and can result in poor filling of the heart and lead to other things like heart failure, which causes symptoms of shortness of breath and peripheral edema. Arrhythmias are also quite common in the hypertensive patient, especially as they get older, because as a part of the whole remodeling process with left ventricular hypertrophy and coronary artery disease, it creates abnormal circuits within the heart. You guys would have done some amount of physiology, knowing the electrical output of the heart and the electrical flow, resulting in systole. And with remodeling, you get abnormal circuits, and with abnormal circuits, it leads to abnormal electrical pathways, leading to arrhythmias. We're not going to dwell too much on that. That's a whole different conversation for another time. But we'll touch on it very briefly. So left ventricular hypertrophy is something that can be detected either clinically. When you are examining the patient, we normally feel for the apex beat, and we notice that that is displaced. Okay, so the apex beat is that lowermost outer part where you can actually feel a pulsation from your heart, and that is displaced. Either it goes more laterally, or it can go more inferiorly. Normally it's in the fifth left intercostal space in the mid-clavicular line. So clinically you can detect it, but also by investigation you can do a test called an ECG, which you should be vaguely familiar with, and an echocardiogram, which is essentially an ultrasound of the heart, where you can actually measure the thickness of the walls. It's been shown that reduction in blood pressure is associated with a reduction in left ventricular mass. There are certain drugs that we choose. You guys should be doing some amount of pharmacology as well. Or not. Or not. But for reference, there's some drugs that are important for you to know for the treatment of hypertension. And it's important that you know about these drugs. ACE inhibitors, angiotensin receptor blockers, so those, your renin inhibitors, your calcium channel blockers, and your sympatholytic agents like your beta blockers can also be used. And also mineralocorticoid receptor antagonists such as your spironolactone, which inhibits the action of aldosterone on the receptors, is also a very useful drug for treatment of hypertension. So for those of you who have done a bit of pharmacology, those are important to know. The diuretics and the beta blockers have not been shown to have as much effect on left ventricular hypertrophy as those mentioned earlier. However, diuretics on their own are very good for hypertension treatment in general, just that it doesn't result in much regression of the LDH. There's no evidence that rapid regression has a better outcome, but there is evidence that if you do improve their blood pressure control, the risk of complications does get better or is reduced. So this is an ECG. I'm not going to go into it too much, but just for you to have an idea as to what it looks like. Looks like graph paper, squiggly lines. Some of it has little bumps, and some of it has lots of spikes, and more bumps and spikes, more bumps and spikes. So you've seen that. I'm not going to get into it. When you come to the clinics, we'll talk a little bit more about ECGs and interpretation, but I just wanted to put this up just to briefly state that there are certain things that we look for on the ECG with all those bumps and squiggly lines that help us to determine whether there's evidence of left ventricular hypertrophy. Okay? Sorry? Oh, what are we looking for? So an ECG can be used to look for many different things. In this particular case, we're looking for left ventricular hypertrophy. Okay? And there are certain criteria. There are a number of them. The one that we talk about most is called the Sokolow-Lyon criteria. I'm not going to stress you out to try and remember that now, but it's called the Sokolow-Lyon, S-O-K-O-L-O-W, Lyon, L-Y-O-N criteria, where we look at the different leads, because there's 1, 2, 3, ABL, ABF, V1, V6, and we look at the amplitude of some of those waves, the QRS complex. So the Sokolow-Lyon criteria, just to touch on it briefly, what we do is we look at the S wave or the Q wave in V1. You'll see V1 up there. It's kind of in the middle. Oh, this doesn't project, but anyway. But anyway, you guys should be able to see V1. We look at that Q wave or the S wave that's there, and we add it to the R wave, which is in either V5 or V6. So whichever one is tallest. So from where you guys are sitting, can anybody tell me who has a higher R wave? Is it V5 or is it V6 in this specific ECG? V5, right? Yeah. So we add up V5, that R wave, okay? And remember, the R wave is a positive deflection, okay? So the R wave is a positive deflection. Please remember that. The Q wave is a negative deflection, which is before the R wave, and the S wave is a negative deflection after the R wave. If you don't have an R wave, you cannot have an S wave, because S have to follow R. So if you have no R, you can't have an S. Clear? Okay, good. And it's also important to note, I didn't really mean to get into this, but when you're looking at the ECGs, you guys are taught at this level that it's called a QRS complex, which is true. But it's important to note that you will not see all three waves in every single lead. Every single lead will not have a Q wave, not necessarily have a Q wave, will not necessarily have an R wave, and will not necessarily have an S wave. Sometimes you might just have a Q wave and an R wave. Sometimes you might have an R wave and an S wave. Sometimes you might only have a Q wave. Okay? But it is still referred to as a QRS complex. Have I confused you adequately? Yes? Great. Mission accomplished. Yes? Yes, very good, sir. So he has noted that there's ST depression in V5 and V6. Okay? So, why is it turning into an ECG class? I was trying to finish short, but anyway. So everybody can see like a ST depression that's down here, and I'm sorry I don't have a pointer, but everybody sees it. So there's a little dip after the QRS complex. I notice I call it a QRS complex, but really it's just a piece of a Q wave, which is very small, and I don't expect most of you to see. There's a very small piece of Q wave in V6. There's no Q wave at all in V5. V5 is just an R wave, and V6 is a small Q wave and a big old R wave. All right? Most of you are not going to see the Q wave in V6, and that's fine. But yeah, everybody can see the R wave. Yes? Okay, good. And what is the R wave? Positive. What is the Q wave? What's the S wave? After R. Yes, somebody knows the alphabet. Excellent. It's a good first step. But yes, so when you add up the R wave in V5 or V6 and you add it to the S or the Q wave in V1, if it's 35 millimeters or more, then that is considered criteria for left ventricular hypertrophy. There are a number of different criteria. There's Sokolow-Land, there's a bag of others that didn't come to my mind right now, but there are different criteria, and the criteria have a certain amount of sensitivity and specificity. We teach you guys the Sokolow criteria, not because it's the best one, but because it's the easiest one to remember. Alright? Because, you see, when in the real world, using the most complicated thing is not always the best thing for you. But you really want to do something quick and dirty. Right? That's the moral of life. That's a life lesson. But the point is that when you're busy, because when you become a doctor, it's not just, you don't have all the time in the world. And you have to be very efficient with your time. Because the most important resource you have is your time. You can always earn more money. You can't always earn more time. In fact, you can never earn more time. Once time is done, it's done. That's it. So you need to choose how you spend your time, and being efficient with your time use is very important. So to use something that requires you to plug in multiple different numbers, or to look in 3 different leads and all that kind of thing, or figures that are hard to remember, are not always things that you're going to use on a day-to-day basis. On a day-to-day basis, you're going to use the very minimum of things. All the things that you learn in school, you're probably not going to use on a regular basis, depending on what you choose to do in the end. But it's still important to have the basics as to understand why things happen the way they do, which is the importance of a lot of the lectures that you're going through now. Because when you come to clinics, you'll be expected to know basic physiology, anatomy, biochemistry, and some amount of pharmacology. Okay? Actually, you're expected to know a lot of pharmacology when you come to medicine, because medicine is medicine. All we do is deal with drugs. So if you don't know about drugs, it's a problem. But we use drugs every day. So it's important to know what kind of drugs you're using and what's going to happen when you use these drugs. Didn't really need to get into all of that, but we press on. So remember I mentioned how we look for left ventricular hypertrophy. We also use a thing called echocardiography. And basically echocardiogram is just an ultrasound. Alright? And it allows us to measure the thickness of the heart. On the left hand side, yes, left, is a normal heart. On the right hand side is a heart with left ventricular hypertrophy. You notice that the wall, it looks like a little donut, right? Why does it look like a donut? A very poorly made donut, but a donut nevertheless, round, have a little part in the middle. So the black part in the middle is where the blood is, all right? And the gray circular part, that is the muscle, or the myocardium. And if you look, you can see that the myocardium is much thicker on the right-hand figure than on the left. The right-hand figure also shows a pericardial effusion surrounding the heart, but that's another story, all right? So this is just one of the ways that we can do it. Don't worry yourself so much about it, but just to know that it's something that can be done. Things like heart failure is something that can happen, again, because of the chronic overload of your heart, and your risk of this increases with however high your blood pressure is. And it results in a lot of what we call remodeling, which is essentially infiltration of your normal heart cells with fibrous tissue, and actually changing the size of your myocardial cells, and sometimes leading to some degree of disarray. You're able to demonstrate the fibrosis by cardiac MRI, as also by biopsy, but you guys are not going to be doing too much of that, so don't worry about it. But the blood pressure is also associated with diastolic dysfunction. Remember I told you that the heart does 2 things? What the heart do? Sorry, contract and relax, right? So diastolic dysfunction is basically a relaxation problem. So whenever we say someone have a diastolic dysfunction, it means that it's not relaxing properly. That's all it means. And that can also lead to poor filling, increased pressures within your heart, and heart failure. And we also spoke about heart failure. You guys remember what heart failure is? Alright. How it will work is that if you raise your hand and you answer. I hear a lot of answers and it sound right, but I can't hear the verbal talk. Yes, sir. Ooh. Yes. When the heart can no longer meet the demands of the body. Alright? So eventually you start off with diastolic dysfunction, but over time you get systolic dysfunction, which is essentially weakness of your heart. We spoke about coronary artery disease, understanding that hypertension is probably the most common risk factor for this, for premature coronary artery disease. Age is also another factor, but is a non-modifiable risk factor until you find the fountain of youth. Older patients, their risk tends to correlate with the level of their blood pressure elevation, especially the systolic blood pressure and the pulse pressure, because that has to do with stiffness of the heart. Because when your blood vessels are stiff, when that heart squeezes and pumps, it causes the pressure to go up a lot higher, and then it also comes down lower because there's not a lot of recoil for that diastolic phase. So your pulse pressure also increases. It's associated with microvascular disease and endothelial dysfunction, which we spoke a little bit about earlier on, and the risk of having a heart attack or myocardial infarction, or known as MI after this, is 6 times that of a normotensive person. So it's a significant risk. All right. I think we spoke a little bit about left ventricular hypertrophy before. I'm not sure why I threw this slide in here, but it increases your risk of the other complications. So once you have left ventricular hypertrophy, you also know that you're going to be at risk for having other things like heart failure, arrhythmias, myocardial infarction with death, sudden cardiac death, a decrease in your systolic function or left ventricular ejection fraction, as well as aortic root dilatation, otherwise known as aneurysm formation. Arrhythmias are also more common, so you can have both supraventricular and ventricular arrhythmias. Those are more common in hypertension, and by looking on the patient, there are certain things that will give you a clue that they are more at risk. That being left ventricular hypertrophy, diastolic dysfunction, which can be measured on echocardiography. Echocardiography would be how you would measure it in most cases, as well as the size of the left atrium, which is also determined by echocardiography, but can also be seen. There can be evidence of this on your ECG as well. Atrial fibrillation is the most common arrhythmia that you will encounter on the wards, okay? In terms of admitted patients, atrial fibrillation is the most common arrhythmia, and hypertension puts you at a significant increase for that, being 40 to 50% more likely in a hypertensive patient as compared to their normotensive counterpart. It's another ECG, more squiggly lines. So this is an ECG showing atrial fibrillation. So this one has more squigglies in it than actually anything else, because this, with atrial fibrillation, you're unable to identify any P wave. Sometimes your baseline can look flat, but also it can be quite irregular and more squiggly. If you look at some of these waves right here, where it's quite irregular. Some of them are actually more sawtooth. So this ECG is truth be told, not completely atrial fibrillation, but it's actually bouncing between atrial fibrillation and atrial flutter. Because these sawtooth waves that you're seeing right here is evidence of atrial flutter, but then it degenerates to AFib around here, and it degenerates again right here. And sometimes that happens where they go in between these two rhythms. It's not uncommon. But don't worry yourself too much about the ECG. Just know that atrial fibrillation is common, and it's higher risk in hypertension. That's all I'm trying to say. It's about a 50% increase in your risk. That's all I need to know. I don't need to read this ECG, maybe not for another year. Brain complications, we all hear about these things. Everybody hear about people who have stroke. We've all known somebody or had some relative who has had it. There are two main types of strokes. There's ischemic and there's hemorrhagic stroke. Ischemic being the most common. The vast majority are ischemic, being 80% of them, and hemorrhagic being about 20%. So ischemic strokes occur because of rupture of a plaque, sudden thrombosis and occlusion, right? So you get ischemia, then eventually infarction, necrosis, and then fibrosis. Hemorrhagic strokes tend to occur because of rupture of aneurysms. Because of hypertension, remember we mentioned that it causes vascular damage. It can not only cause atherosclerosis, but it also causes weakening of the vessels and aneurysmal formation. So part of those aneurysms can be in your brain, but it also affects other organs, other vessels. Hypertensive encephalopathy may also be seen. This is actually a very poorly understood kind of thing. We don't know really why it happens. There are a number of theories, but we know that in some people, when their blood pressure goes up very high, they become very confused. All right? They become very confused, they become delirious, and it's because of the hypertension, and the treatment for that really is just to lower the blood pressure. And it is considered to be a hypertensive emergency. So hypertensive emergency means you need to lower that blood pressure within a number of hours. Because you can have a high blood pressure, but it is not an emergency. Because the timing? Hours. So you want to lower it over a course of hours, like up to 6 hours. For hypertensive emergencies. For which hypertensive encephalopathy is one of them. Myocardial infarctions and heart failure are others. Right. So other things. So it's important to recognize that hypertension is the most common modifiable risk factor for stroke, and the risk of ischemic stroke is significantly reduced by treatment with hypertension. By lowering your blood pressure by 5 to 6 millimeters of mercury, reduces the risk of dying from cerebrovascular disease by about 35 to 40%. The reduction is not as much as with hemorrhagic stroke. So it's still there in hemorrhagic stroke, but it's not seen to the degree as with ischemic strokes. And usually, again, it's just a process of accelerated atherosclerosis. And as we mentioned, cerebral hemorrhage being the result of microaneurysms called Charcot-Bouchard aneurysms, which are usually at the junctions of where there's a bifurcation, usually in the circle of Willis in your brain. This is just a CT scan. You'll see some arrows there. You'll notice that there are parts of the brain that are darker when you compare it to the other side. And this is an example of someone with an ischemic stroke, where there are two areas of ischemia/infarction here. They're actually probably confluent, but depending on the cut, it makes it look as if they're two separate regions. This is an example of a cerebral aneurysm, right? Usually at the junction, so you notice that it's right at the bifurcation. Right, that's quite common because that's where the most shear stress is on the vessel, so it causes weakness there. This is a CT scan of somebody who was at a hemorrhagic stroke. You'll notice that there is a hyper intense white region over here, and you'll also notice that the area around it are darker than the normal tissue. So the white area is or the lighter gray area, kind of 50 shades of gray. The lighter gray area is blood, and the darker area around it is actually cerebral edema. So there's actually water within those cells, which causes it to look black on the CT scan. All right. Not expecting you to read CT scans here today, but just give an idea as to what they look like and what this pathology can look like when you scan the patient. Yes. It's a hemorrhagic stroke. So that's blood. So the light gray that you're seeing there is blood. So basically you have an aneurysm that just blew up. So it's shows some blood in your brain, and it's compressing the brain and also raising intracranial pressure. But that's a conversation for a different time. Hypertensive encephalopathy. All right, so we spoke about this, we mentioned it earlier. And essentially it's a symptom complex where you have severe hypertension, you have alteration in your mental state, usually due to increased intracranial pressure. You can see it by looking in the eyes, you see papilledema, and they can also have seizures as a result of this. We don't know what causes it, but we know that you need to lower the blood pressure very quickly, matter of hours. We mentioned the effects on eyes. There's something called hypertensive retinopathy, which you will be expected to know about at some point in the near future. There are 4 grades. I'm not going to bore you with it, but it goes from basically narrowing of the vessels or constriction to the last grade 4 being papilledema. Right, and in between you have various changes in the actual blood vessels and also something called background retinopathy, which is exudates or cottonwool spots and flame-shaped hemorrhages. And the flame-shaped hemorrhages are as a result of, again, small aneurysms that burst, but aneurysms in the retina, the vessels that are in the retina. All right? So you can see that there's a lot of recurrence of the themes, right? Hypertension affects blood vessels. It can cause both narrowing, but it can cause aneurysmal formation and aneurysms rupture. That's just what they do. All right? Happens in your brain, happens in your eyes. This is just a little cartoon, again, showing some of the different features of the hypertensive retinopathy, the flame-shaped hemorrhages, cottonwool spots, but you can also get hard exudates as a result of it, and sometimes some macular edema. More of the same. This is grade 4. It's also, more importantly, this one is really just meant to show papilledema, which doesn't really project that great here. Yeah, I think this might help a little bit. With an eye of faith, you might notice that, so the optic disc is that area where all the vessels are coming from. Everybody see where the vessels are going to? Almost in the middle? It's a little bit off center. But with an eye of faith, you might be able to see that there's something that looks like a donut around where those vessels are going. Yeah. So that's not supposed to be, because your disc is supposed to be flat. When it's swollen, that's called papilledema, and it's a reflection of raised intracranial pressure. So when your blood pressure gets really, really high, it's high inside your brain, and it's transmitted to the optic disc, which results in papilledema. Okay? So hypertension is one of those things that can cause papilledema. If you have bleeding inside your head and other things like that, that will also cause papilledema, because that's a more local cause of raised intracranial pressure, as opposed to the systemic cause of elevated blood pressure. And it's important to look in the eyes of your hypertensive patients, and not just look in your eyes like stare at them, but actually by looking into the eye using an ophthalmoscope, looking for evidence of hypertensive retinopathy, because this allows you to risk stratify your patients, because if you see grade 3 or stage 3 or 4 retinopathy, so stage 3 being the exudates and the hemorrhages, and 4 is papilledema. So if you see any evidence of that, that means that they have a high risk of stroke, cognitive decline or dementia, and death due to cardiovascular causes. So it tells you their risk or their prognosis just by looking in their eyes. Right? Your kidney is also another victim. Hypertensive nephrosclerosis is the second most common cause of end-stage renal disease worldwide, leading to hemodialysis, dialysis, which can either be hemodialysis or peritoneal dialysis. And it's due again to ischemia, because you have atherosclerotic changes. So you have ischemia within the actual glomerular apparatus, and the hypoxia that occurs leads to tubular atrophy and fibrosis within the interstitium of the kidney. All right? Which in turn leads to arterial stiffening and an increase in your pulse pressure at the arterial level, which causes your kidney to lose a lot of the autoregulatory abilities. And on a histological basis, you'll see glomerular hypertrophy. There'll be evidence of hyperfiltration and focal segmental glomerular sclerosis. Don't worry about that too much. So there are a number of things that put you at risk of it. And historically, these patients normally have a long-standing history of hypertension prior to being found to have kidney disease, because it's also important to note that kidney disease in and of itself, or renal failure, can also cause you to have hypertension. So this would be considered secondary hypertension. So often when patients present for the first time with kidney failure and a high blood pressure, we wonder which one came first. Was it the hypertension that was undiagnosed that led to renal failure, or was it that the renal failure is now causing hypertension due to the disruption of the hormonal mechanisms with the renin-angiotensin aldosterone system? So usually there's no other etiology for the kidney disease, so there's usually an absence of diabetes before you can call the because before you can blame the kidney disease on hypertension. And they can have proteinuria, but it's usually not a lot, less than 2.5 grams for the day. If you're having a lot of protein, if you have nephrotic syndrome, then hypertension is unlikely to be the cause of that, and you have to look for other causes. So don't blame it on hypertension if you have nephrotic range or proteinuria. Urinalysis usually doesn't have any cells or any active sediment. Again, I said the absence of diabetes. And usually if you have kidney disease from a hypertension, you have evidence of other end organ damage. So left ventricular hypertrophy or retinopathy being the two associates. And there's also a family history of hypertension in these patients with kidney disease. African Americans, or people of African descent, I should probably say, are at higher risk of having renal disease, and the age of onset tends to be younger, of their hypertension being 25 to 45 years. There are certain characteristic appearances of the kidney on biopsy, which is listed there: hyalinization of arterioles, intimal thickening, glomerular ischemia and fibrosis, and the proteinuria that you get is due to glomerular injury. And proteinuria is also a negative prognostic sign because it means that you're going to have damage to other vessels in your circulation, especially your cardiac vessels. So proteinuria and cardiac disease are very strongly linked. This is kind of what you look like. You get a lumpy, bumpy kind of surface if you look at the kidney grossly, almost like a flea-bitten appearance. Macrovascular disease, I think we should be nearing the end soon. You have peripheral arterial disease, aortic aneurysms, aortic dissection. We've kind of spoken about these, but it also happens in some of the larger vessels, being the aorta, being the primary one that we worry about. Peripheral arterial disease, a reflection of the same process, and is diagnosed by having an ankle brachial index of less than 0.9. So you measure your pressures at the ankle as well as in your arm, and you compare it, and then the ratio, if it's less than 0.9, so if the pressure is lower in the lower limbs, then you can see that proportionally there is a reduction in flow, and this is a criteria for peripheral arterial disease. Most of them can be asymptomatic, but then they can present with claudication, which is essentially pain in the calf on walking, and it's usually over a certain distance each time. And worst case scenario, you get critical limb ischemia and gangrene. So you basically lose a limb. Aortic aneurysms, reflection of the same, localized dilation of a blood vessel. There's a risk of rupture, and most of the cases are caused by atherosclerotic disease, but some of them can also be caused by genetic diseases involving usually the collagen function. Things like Marfan syndrome is one typical example of that. Because hypertension causes greater wall tension due to reflected wave, and eventually get acceleration, and it is usually at some point of weakness where it starts to expand, and they all rupture if given enough time. These are the different shapes of aneurysms, kind of saccular, fusiform, and the third one is when it bursts. Aortic dissection, it's a serious thing, and it's serious because King George II died while straining on the grapple. Because when you strain, you increase your blood pressure, and you also increase your peripheral arterial resistance. And if you have an area that's vulnerable, you'll cause it to be damaged even further, and in this case tear, where there is a tear in the intimal layer. And because of the direction of flow of the blood, if it tears in the direction of the blood continues to push into this opening in the intima underneath it, within the actual vessel wall, and it just tears it all the way down. And as a result of the tear, it can knock off other branches, like your renal artery, for example, or your splanchnic circulation. So you can get bowel ischemia or ischemia to your kidney as a result of the artery dissection. And if it goes down far enough, it can go down into your iliacs and block off circulation to your lower limbs as well. So it can be pretty significant. And the reason that this occurs is because there are small vessels called the vasa vasorum. So these are vessels that supply your vessels. Because of atherosclerosis in these vessels, you get ischemia and the deterioration of the collagen as a result of that. And of course, there are other collagen vascular disorders like Marfan's, as I mentioned. There are two main classifications of aortic dissection according to the Stanford classification, type A and B, and the only difference between the two is that type A affects the ascending aorta, alright? And that's it. If it doesn't affect the ascending aorta, it's type B. We're just going to talk briefly about how to identify target organ damage, and we've mentioned most of these already. We mentioned retinopathy, which is found simply by using your ophthalmoscope. Clinically, a fourth heart sound is evidence of left ventricular hypertrophy or displacement of your apex beat. ECG, we already spoke about. Chest X-ray can show also cardiomegaly. Urinalysis, looking for protein in the urine, is important. The echocardiogram, we showed you a bit of that earlier on, as well as looking for vascular bruise. So if you have something like carotid artery stenosis, because of atherosclerosis, you can hear a bruise in your neck. But you can also have renal artery stenosis. So when you're examining the abdomen, you listen over the renal artery, which is about an inch above and to the side of your umbilicus. You can also feel for diminished pulses, especially in the lower limbs, which is evidence of peripheral arterial disease. You send these patients for blood tests, such as what we call the urea electrolytes and creatinine. We would look for other risk factors for cardiovascular disease, for example, diabetes. So we do a fasting sugar and a HbA1c, and we also look for evidence of hyperlipidemia. Okay, we may do blood pressure in both arms, ideally, and you use the arm that has the higher pressure. Okay, so ideally you should use both arms, check which one has a higher blood pressure, and use that one for follow-up thereafter. There's a strong link between hypertension and diabetes. I mentioned that we do check for it, and hypertension increases the risk of diabetic retinopathy as well as nephropathy. And the retinopathy itself can be reduced by blood pressure lowering. So the diabetic retinopathy can be reduced by controlling your hypertension. So again, hypertension being very important, and there is an interplay between that and the other disorders. Hypertension, chronic kidney disease, again, we spoke about this earlier, that it can be a cause or it can be secondary to. It's the most common cause of death in patients with chronic kidney disease. It's going to be cardiovascular, usually due to heart failure or arrhythmias. And chronic kidney disease itself results in inflammation and calcification of the coronaries, accelerating your coronary artery disease. So hypertension worsens your kidney disease, and kidney disease worsens your cardiac disease. And your targets are different. You want to have a lower blood pressure for these chronic kidney disease patients to reduce your progression to renal failure and dialysis. ACE inhibitors or ARBs are medications of choice. And you have to be careful because those can cause hyperkalemia. But a small increase in the creatinine or the potassium is not really a contraindication to using these drugs because they have benefits greater than that. Other things, try to avoid them smoking because that will make their blood pressure control worse and also will increase their atherosclerosis. Looking for other things like family history, dyslipidemia, encourage them to exercise, reduce their risk. Also use of drugs, more street drugs like cocaine, and an age greater than 55 are all additional risk factors for hypertension and worsen your risk of complications of end organ damage. So in summary, hypertension affects most organs. I think we can all agree with that based on what's said. And it's an important factor in the morbidity and mortality of older patients. And there's a significant interaction between hypertension itself and multiple other risk factors such as diabetes and chronic kidney disease. Alright, so I'll stop here and I'll invite any questions.